Good morning, everybody. It's great to be with you here virtually today. I'm Stacey Chu, one of the first year fellows over at UW. Of course, you guys haven't been able to meet me yet in person, but I'm looking forward to meeting you all hopefully very soon. I did originally my training in the Midwest. I was born and raised in Iowa, where I did my medical school in, and then I did my residency training in St. Louis, and of course, I'm here now. So I'll go ahead and get started. Hopefully you guys can use your microphones or ask questions as you want to as we chat today. So today we're going to be talking about a review on aspirin-exacerbated respiratory disease. I'm going to go ahead and turn off my camera so you guys can focus on the slides. I have no disclosures, so let's just go ahead and get started here. Today's objectives are going to be to understand the pathophysiology of the clinical presentation of Aerd, to review the current management of Aerd and the known mechanisms of treatments, and to explore future possibilities in the management of Aerd. To help us on this path, we're going to follow this roadmap. We're going to be talking about general introductions, including that clinical presentation, working to understand how mechanistically our patients present with symptoms that they do have, and that will help us to understand mechanisms of treatments that we do have. And then we will talk about how we can explore into the future of Aerd. So for our introduction, I am up here right there. I'm going to be leading us through. So to start off, I did want to talk a little bit about my first ever patient that I had that had Aerd. This actually was a patient that I didn't have personally, but I had experience kind of with understanding their story. I was on my first ever MICU rotation as an intern in internal medicine, and I happened to see one of my friends, the allergy fellow that I knew, walking through the hallway kind of late on like a Friday afternoon. I thought that was a little bit odd, so I asked him what was going on. And he mentioned that, he was here because the cardiac ICU had a patient there with a STEMI who needed aspirin, and they had Aerd. And he told me a little about their history and just what was going on, that he was there to help with the desensitization. Now, I thought that was really interesting because before that time, of course, I had known a little bit about Aerd. We learned about that in medical school, but I never really stopped to think about clinically what's going on within our patients and what does that mean for them moving forward. I knew kind of the initial presenting symptoms and signs, but I didn't understand how patients had their lives impacted by Aerd, and that was kind of my first eye-opening exposure. So with that, I had some questions. I had questions about what's going on in the body, why do patients have symptoms, how is it treated, and how do those treatments really work? I wanted to know if there were any risks that this patient might be experiencing, and how his life was going to look in the future. So to help us answer some of these questions, let's talk generally about the presentation of Aerd. Of course, I know that this is something that everyone in this virtual audience has a lot of experience with, and it's something that most of you will be very, very clear on already, so we'll go through this part fairly quickly. So for the initial presentations of Aerd, it's one of the conditions in AI, of course, that we manifests more so in adulthood than in kiddos, which is unique. We see that, of course. And with the presentation, typically it starts out with this kind of initial like rhinosinusitis picture. Patients will have that starting in, and then they'll have this more so adult onset asthma. Of course, the asthma can occur in kiddos, that's seen as well too, but it really is this really interesting adult onset asthma picture. They frequently then will kind of go unnoticed in terms of things until they maybe develop some nasal polyps. They start to get evaluated by otolaryngology potentially, and then at some point along the way, they'll have a reaction to COX-1 inhibitors, and we're going to, of course, talk more specifically about that. The reaction that they have typically is manifested in terms of bronchoconstriction, rhinorrhea, headache, eye tearing, sneezing, congestion, and also sometimes an abdominal pain, nausea, vomiting, angioedema, urticaria. These here that are in parentheses are the ones that are, of course, less common. And typically with these kinds of presentations, they do happen within, 60 or 90 minutes or so. So knowing what these presentations look like and understanding kind of what that is in terms of what our patients will look like is just one part of the picture. There still is that question of what is AERD when our patients ask us, what do I have? And that's the question that we're going to be diving into a lot more today. I think if you think about what AERD isn't, that's a little bit more straightforward. We know that it's not specifically IgE mediated. We know that it's not something that's clearly inherited, and it's not something really due to the environment. And we also know that it does affect a really good amount of patients, a good chunk of our patients. There's about 1.5 million patients in the US, about 7% of patients with asthma that are adults, and about double that, 14%, with severe asthma. And this is our first QR code popping in today. So throughout this talk, you guys are going to see QR codes in the top right corner of the screen. That normally means that there's just something that I'm referencing that I'm going to be talking about. So here it's just the study that this information came from. I'll kind of remind you guys as I'm chatting that this is going on, but that's always going to be up there for you guys to access. If you have any issues, please let me know. I'm happy to send you the information following. So to look into this, we're going to pull up our questions again as a quick reminder before we follow along on our map to best understand the pathophysiology of AERD so we can really understand what we can offer to our patients and how that really helps them. Here again you see me, and now we have our patient with us. So as we mentioned, we have these primary symptoms with AERD, and we're going to be talking specifically about what we can do for this. Of course, one of the initial mainstays is just avoiding those medications that are going to be bothersome until somebody can get evaluated. Of course, we know that when patients want to get evaluated in our clinics, it can take some time. So these are things that we can recommend to them, just using those highly selective COX-2 inhibitors. Those have been shown to be safe. Even if on the labeling sometimes there is warnings or whatnot, there's really good safety for patients using this, and they tolerate these quite well. A lot of patients will use more of a, Tylenol, acetaminophen, but these even at high doses can cause them issues, so that's just something to keep in mind. Things that we can talk about for management with patients include primarily these categories. We talk about aspirin desensitization, leukotriene modification, surgical interventions, use of biologics, and dietary changes as well. To best understand how these treatments work, what's going on in the body, we're going to take a closer look into the pathophysiology that we know. So of course here there's just one of the diagrams that I'm sure many of us have seen. This outlines kind of specifics in terms of what's going on in the body and what happens with our patients, but realistically, I know that everybody in this room is very familiar with this diagram and understands all of the specifics of it, but most of our patients, they really won't understand something like this. It's going to be something where they are seeing a lot of details that don't really make sense to them. So we're going to take it back to the beginning and talk about some basics. So here we have arachidonic acid, which is an unsaturated essential fatty acid. And the arachidonic acid is very important because it becomes leukotrienes and prostaglandins. And we're going to talk a lot more about each of these two groups. Starting with the prostaglandins, there is this really, really beautiful pathway that is well laid out here with the source that I had located. And this specifically shows a lot of details with the prostaglandin pathway and the leukotriene pathway, and kind of reminds us where NSAIDs come into play. This is something that I'm going to be continuing to reference, as I think it's quite a good source. But as we chat, once again, I want it to be super clear for our patients when we're walking them through, so we're going to start once again from the beginning and talk about things specifically. You might have seen on that last slide that I had this arrow over at PGD2, and here I want to show it again in the pathway. So specifically, as we're thinking about how the body processes things and how these reactions manifest, I want us to think about PGD2. We're going to talk soon about PGE2 and then some of the leukotrienes. So in the body, we have arachidonic acid. Hopefully you can see this here. And this transitions down hopefully, oh, my computer just froze, apologies. And this transitions down via the cyclooxygenase 1 and 2 that's located on mast cells, macrophages, eosinophils, Th2 cells, ILC2s, and it becomes this PGE or PGH2 intermediate. And then that PGH2 intermediate goes through PGD synthase and becomes PGD2. And PGD2 is quite important because it is one of the primary mediators in a lot of reactions in the body. It goes into three main targets: DP1, which predominantly is involved in vasodilation, things like that; DP22, which is also CRTH2, and that stimulates and activates things. So specifically, it stimulates IL-4, IL-5, IL-13, and activates eosinophils, basophils, those Th2 cells, and ILC2s. And then we have TP, which is the thromboxane receptor, and that's involved in smooth muscle constriction. So PGT2, very important in the body, and we're going to talk about how this is a little bit different in our AERD patients versus in the regular patient. So now on the flip side, we're going to pop over here and we're going to look at PGE2. So just remember PGD2 here, and then we're talking about PGE2 over here. So once again, here we have our pathway that we had talked about earlier. And very, very similar. So on these macrophages, epithelial cells, fibroblasts, and whatnot, we have everything cycling through down to PGE2. And importantly, PGE2 is this anti-allergic and anti-inflammatory cell that specifically inhibits activation of granulocytes, mast cells, T cells, ILC2s, and importantly here for us, phosphorylates and inhibits 5-lipoxygenase. So PGE2 really is a brake for the system that we're going to be talking about. I wanted us to keep this in mind as we talk about the leukotrienes. So on the leukotriene side, once again, these are shown up here in really beautiful detail, but I did want to specifically pull up this diagram where you could see kind of a little bit closer on that molecular structure, because that is inherent to their name. This is leukotrienes. Knowing this and seeing this, we're going to talk once again about just the very basic building blocks of what this pathway is, so that when we talk to our patients, we can explain things to them in a way that they will hopefully best understand. I'm sure everyone here already is doing this, but just as a quick reminder on this pathway, we have arachidonic acid that is eventually converted to leukotrienes of various sorts, partially through this 5-lipoxygenase. And wouldn't it be nice if this was all that really was in the pathway, but of course there's more. So in this process, 5-lipoxygenase actually works with FLAP, which is a membrane protein, and that transitions arachidonic acid to this LTA4 intermediate, which then, depending on which hematopoietic effector cells you have, transitions to either LTB4 or LTC4, On neutrophils, it would be LTB4. And then on our primary cells, which we're going to be talking about, which is mast cells, dendritic cells, macrophages, eosinophils, basophils, it's going to transition down to this LTC4. And this is where we really have our name of the cystinoid leukotrienes. So LTA4 in this process is preferentially conjugated to reduce glutathione, and it forms this peptide lipid conjugate known as LTC4. And you can see this right here. And then LTC4, when it's exported to the extracellular space, is converted to LTD4 and also here LTE4. Now these are really going to be important for us because LTD4 is a very potent but short-lived bronchoconstrictor. And then LTE4 is a little bit less strong, but it does persist longer in the body, which is really going to be important for us as we look into some of our literature. When we think about the actions that these do have, we think specifically about where they bind in the body. So here we have cis-LT1, 2, and 3. And the cis-LT1 is this high affinity LTD4 receptor. It's on the airway and vascular smooth muscle. Cis-LT2, right here, binds to C4 and D4, and it's on endothelial and epithelial cells in the airway. And cis-LT3 binds to LTD4 on mucosal epithelial cells. And all together, with this binding, the cystinoid leukotrienes work to do a number of things that are quite relevant for our patients. They induce this vascular leak. They cause this smooth muscle constriction. They cause mucus secretion. And importantly, they are involved in eosinophils. So now that we've gone through this, we've chatted briefly about both the leukotriene pathway and the prostaglandin pathway, and we talked just a little bit about how those interplay together. And of course, we have mentioned that our main point of the talk today, the NSAIDs, aspirin, etc., would be involved up here in this cyclooxygenase 1 portion of the pathway. And that generally, if you can think about this, of course, when you're blocking off this, you're going to have decreased amounts of PGE2, and then you're going to have increased amounts of leukotrienes. But even with understanding this, that's where the question really comes in of how is this relevant for our patients and what's really going on? Because if you think about it, if this is a typical pathway that is in most humans, then why specifically do our patients have the symptoms that they're having? Truly, what is going on in their body and why do they specifically have these differences that other people don't? And this is where I went into the literature. I'm sure a lot of these are things that you all already have read through and you've committed to memory, but we'll just have a nice review of the literature available. And we're going to start off with this study by Katie Cahill's group. Once again, here is that QR code if you guys wanted to scan in to get that. And this paper actually had quite a few more findings that were very interesting, but importantly for the purpose of, this area of our talk, they looked at LTE4 in patients who tolerated aspirin, as right here, you can see that, very, very small bar. And then they had two different groups who didn't tolerate aspirin, and these are the AERD groups. And these two groups, there are some more specifics in the paper that I won't get into this for the sake of time, but the important thing is to realize that both at baseline, the AERD patients had a higher level of LTE4, and they also, when they had an aspirin challenge, had a much higher level. And I think this is something that all of us are aware of, that there are specific parts in the body that are a bit different in our AERD patients that leads partially to this increase in leukotrienes, and we're going to chat more about that and things that we do for it. The next thing that I wanted to show here is this study by Yoshimura in 2008, and this specifically I wanted to highlight more about the PGE2 as well as also cystinoid leukotrienes and PGD2. And they looked at nasal polyps in a variety of patients. They had controls, non-asthmatics, aspirin tolerant asthmatics, and then aspirin intolerant asthmatics. And as you can see here, for PGE2, the controls had a much higher level, and then as you kind of trickle downwards, there's a much lower level of that PGE2 in our patients. So coming together, we've seen that clear study, and there's so many more, of course, that we could have talked about that show that there seems to be this increased amount. And then we had the other study which showed that there was this decreased amount of the prostaglandin E2. Of course, as we all know, there's a lot more to it than what we had just briefly mentioned there, but that's really the meat of it. And the next thing that I think we want to just fully, clearly understand is how these interplay together and what that means for our patients. Of course, we had talked about earlier that prostaglandin E2 is involved as a brake to that leukotriene system, and that's quite relevant in humans. And then now I wanted to talk about just this study, which really I think beautifully shows that. So this study by Stacey and colleagues did reveal the effects of inhaled prostaglandin E2 in patients after an aspirin challenge. So here you see placebo, and here you see inhalation of PGE2. And you can see that if you kind of block out this portion here, this is what we really expect for our patients. You know, we have them take an aspirin challenge, and then we do see that they have this drop in FEV1. Whereas if they have the inhalation, it seems to stop their reaction here, which is something that, of course, I know everybody is very familiar with, but I wanted to make sure we were just thinking about this before we talk some more. And then here as well, we're looking at their urinary leukotrienes, specifically LTE4. And we do see that with the placebo group, following that aspirin challenge, their levels really started to rise up, whereas in the group that had the PGE2, they don't have that rise, and that's something that is quite important for us to think about. So now that we've had our basic introduction to the pathophysiology and the symptoms of our patients, let's dive deeper into understanding what we specifically can do for our patients and what we know about the mechanisms in the literature there. Just as a reminder here, we're going to put up our symptoms. Of course, we know that whenever you're managing patients with AERD, there's different things that you think about. You think about managing each thing individually, and then you also think about, managing things as a whole in a way that will target the molecular pathways to help out each of their different symptoms. So today we're going to be talking about aspirin sensitization, leukotriene modifications, a bit about surgical intervention, the use of biologics, we're going to spend a lot of time here, and then just briefly some information on dietary changes. And of course, aspirin sensitization is one that is near and dear to all of our hearts, so we're going to start there. To talk about aspirin sensitization, I just pulled up the most recent work group report from the Quad AI. Once again, here you can scan this if you would like to access that and follow along. And I know that everyone here has really already familiarized themselves with this, so we'll just go through it briefly. Here is this very nice pathway that they had included that I think it makes a lot of sense to all of us. If you have patients that are still having issues with nasal polyps, still having issues with asthma, etc., and they do have this history of reactions to the COX-1 inhibitors, then of course you would go down this whole pathway to consider desensitization for them. And one important thing that, of course, everyone here already does is evaluate patients for any contraindications. I just wanted to put this here as a brief reminder. Contraindications would be things like poorly controlled asthma, or importantly, significant nasal polyp burden at time of desensitization. Really, it's the best to do this kind of surgery on the nasal polyps before, which we'll talk about later, and then to evaluate for all of these other potential aspects of our patient's history that would be pertinent for us in this setting. And if your patients don't have any of these, then here they outline really well So options we have for our protocols, and really here they have both, the oral aspirin, intranasal, they have the 1-day protocol, the 2-day protocol, and realistically, I think all of us know that depending on what facility you're at, there is just typically a protocol that very likely that facility would utilize. And, doing a quick review, there's quite a few that pop up for different groups. So I'll just move past this and we'll talk about what it really means for our patients if they can pass the challenge like this. So here's that table again, just showing the COX-1 inhibitors and the COX-2 inhibitors. And of course, this is the group here that patients pretty much always would have tolerated. And then this is the group that really they would not have tolerated in these, only in the high amounts likely would bother them. But these are the ones that they can think about having a tolerance of after that challenge or that desensitization, which is really excellent. But of course, there's a lot more to it for that. And I think importantly, we want our patients to understand that when they go through an aspirin desensitization, it's a lot more than, tolerating NSAIDs. I think that's a really big aspect for them, and being able to control pain or whatnot is incredibly important. But as we know, there's improvement all across the board. You have improvement to asthma symptoms, you have reduced needs for oral steroids, they have improvement and the sense of their smell and taste, they have delayed regrowth of nasal polyps, and they need fewer polyp surgeries. And that's really an amazing thing. In different studies, including the Scripps patient survey, about 91% of patients who had been desensitized reported that they felt they had an effective desensitization that was beneficial for them. And I think that's a pretty good number. Now, 91% of patients being happy with something is quite significant. But when these patients are thinking about things, I think historically patients, they do want to be part of their care. It's a really important thing that is coming through medicine, is this dual partnership. And a lot of patients, despite knowing all this, they want to know, so how does this work? And what's really going on in my body? And can I trust this kind of process? And I think recently, at least recently for me, it's something that I had kind of been learning about, is that we do know a little bit about what's going on in aspirin desensitization. Bolay in 2018 looked into adult patients who had underwent oral aspirin desensitization followed with daily aspirin for 6 months. And they measured a number of markers. They measured LTC4, prostaglandin D and E, and then this TSLP, which we're going to come back to at the lower end part of our slides. And they found that with aspirin use, there was this decrease in PGD2, which we know is higher in patients with AERD. And there was this relatively constant ratio of the LTC4 and PGE2, which is really interesting. Here, once again, I'm just gonna have you guys keep an eye on this one because this TSLP is gonna pop back for us in the later slides. But I think this is really interesting because, back when I was a resident first hearing about that patient, I don't believe that I was aware of this quite yet, and that's something that's really exciting to be able to explain to patients what's going on in their bodies. So now moving on, we're going to talk more about Leukotriene Modification. This is something that I know a lot of us are incredibly familiar with, including the pathways and where things work, so we'll just do a brief review of this as well. With leukotriene modification, I just want to remind us that these cysteine leukotrienes do cause these specific, effects. They have the vascular leak, eosinophil, mucus secretion, smooth vessel constriction, and this happens more so in our patients because they do have that higher level of baseline and also a much higher level after aspirin. And then here, as a quick reminder, we have our pathway that really gives us an understanding of what's going on. And up here, we have 5-lipoxygenase leading all the way down. We have leukotriene C4, specifically transitioning into D4 and E4 here, and then binding to our receptors. And of course, in these portions, I think all of our minds go to areas that we know we already have medications for, right? So if you CF5-lipoxygenase, I think any AI doctor in their mind just goes and says, oh, Xyluta, and they just kind of pops in. And that is something that I know is very familiar to us, so I won't spend too much time there. As well as monoleucas. This is LT1 effector. Monoleucas is one that I know all of you are very familiar and we all use quite frequently. So I won't talk specifically about that, but I did want to just put in one study just to remind us, which I already know we know, how beneficial it is. Oh, apologies for that. Sorry about that. Computer froze for a second. So here we have our overall knowledge of what the cis-natal leukotrienes do in the body. And here's what our patients can think about as we utilize these leukotriene modifications for them. They can look forward to increased FEV1s, improved smell, nasal symptom scores, decreased SABA use at baseline, and the safer silent desensitization. There are quite a few studies, of course, that I think all of us have seen regarding the use of these various leukotriene modifiers when someone is being challenged, and of course we know that they do help with that desensitization, and they do help our symptoms to have a lot less of an impact for our patients. This study is one that I definitely wanted to bring up. It's something by Bond in 2021, and it was very interesting to me because it looked at patients that have AERD and ones that were getting these leukotriene factors, as well as other patients who were not. And it really showed that, for these patients who otherwise, did report improvement to symptoms and whatnot, they still did have quite this high level of LTE4. And, this paper brought up that these numbers were still quite high, and it mentioned that potentially there might be benefit in targeting other aspects of the system to even better help our patients. And I think all of us agree that's a really good idea, which is why a lot of us already are using biologics. So now we're going to talk quite a bit about biologics. And
Hey, wait a second, Stacey. That slide is too complex to blow past it that quickly. What's the point of that slide?
so in this slide, this is LTRO treatment when patients with ARD and aspirin tolerant asthma. So sorry for blowing past that. I didn't mean to. And these are patients where they had all gotten inhaled corticosteroids and LABAs, in this kind of all across the board you can see. And then in both the aspirin tolerant asthma and the AERD patients, they had gotten LTRA. And here they were comparing, what that really showed in the body. They were trying to figure out, is this truly blockading, I guess, everything, not everything, but, more so considerably enough? Or is there potentially more targets? And if you see here, kind of, you can block out this middle portion here. And these groups, kind of at the other aspects, there is quite a high amount of the serum LTE4 in these patients with AERD, even if they were on these treatments that typically patients are on and do relatively well on. They still had something more there, which is an indication that, really there's, I think, a lot more that could be targeted here. Hopefully
So,
that.
are you saying that leukotriene inhibitor, the drugs we're used to, don't really work by the mechanism we think they do? People are still making substantial amounts of LTE4 or excreting it?
Yeah. So this is something where it's quite interesting. There's a little bit more data that I'm going to be talking about coming up, but a lot of the things that people do help patients. Definitely it does. There's improvement to their FEV1, there's improvement to their symptoms, there's improvement across the board in a variety of categories. But when you really look at it molecularly, it's not targeting everything. It's not doing really everything, which is why I think in managing our patients, we reach for so many various categories on things that we can do for treatment because, we do have nasal polyp surgery, and then we also do have the aspirin desensitization, and we have leukotriene modification, and we have biologics. And I think For some patients, of course, here you see there's, just as any study, there's a good amount that, yeah, they did have these levels that were quite controlled, and they probably wouldn't need anything further than what was already, here. But then I'm sure all of us have had those patients where you give them the medications that, maybe 9 out of 10 patients had benefit with. And for those patients, there just seems to be a little bit more something, a little bit where they're just still having symptoms, and you're wondering, why is that and what can we do? And I think, I see this as a good thing that we had this information. I think there's a way to look at this and say, oh goodness, well, it's not working. I would say, I think this is a really good showing that the medication does help for a lot of patients. And if a patient comes in and they're asking, why am I still having these symptoms? Then I think you could explain to them that, there's a amount of people that just do need a little bit more. So that's how I would visualize this. And I think the good thing is we have quite a few treatments that we have to be talking about soon, and then quite a few that I'm going to be talking about in the further explorations part of this talk. Does that kind of make sense and help everybody? Okay, I'll move on. So here we have our star biologics, things that of course we use quite a bit and that we know are quite helpful for patients. This was a really nice summary table, I thought, of the 4 biologics that I think we are the most familiar with. We'll talk a little bit more about another coming up in the future directions. And once again here, if you wanted to pull this up, there's that QR code for you. But out of these, we are going to start out with dupilumab. Dupixent, dupilumab, all of us, know and love this. We think, and our patients definitely have a good response with this. So dupilumab, as we all know, of course, is this monoclonal antibody that targets IL-4 and blocks intracellular signaling of IL-4 and IL-13. That helps to maintain that immune response of Th2 cells. And now we're going to talk a little bit about just the literature that we have and use of dupilumab in our patients with AERD. So this study here, I included this title just to kind of help us all to read this and solidify this. Of course, I'm sure everyone's already read all of these things, but as a nice review, here's this title for you. And they were looking at dupilumab as an add-on therapy for chronic rhinosinusitis in patients with nasal polyps and AERD. And here they had this really nice chart showing improvement to patient scores regarding their SNOT-22 score, which as we know is that evaluated kind of marker for nasal polyps and chronic rhinosinusitis. And as you can see, as patients persisted on dupilumab, they really had a good improvement to their scores. Very, very clearly, nearly everybody here immediately had an improvement, and then by the end definitely had significant improvement to their scores, which is quite good. And then additionally here, they did look into a number of the other aspects that are very important to us. They looked into this LTE4, and here you see the beginning of the study, and by the end, once again, this had decreased as well. They looked at FeNO, which is, as we know, very, very important for our patients and their asthma, and this, once again, by the end of the study, had come down. And then they also looked at some other aspects that we're not going to talk too much about. They looked at this TARC, which is the thymosin activation regulated chemokine. And I thought that was quite interesting as well, but for the sake of time, we won't get into that today. Next, I wanted us to look a little bit at this study here, which looked once again at dupilumab and nasal polyp burden and asthma control. And this, once again, really beautifully, I think, outlines how much of an improvement patients can get on dupilumab. Here's our AERD patients, here's our non-AERD patients, and here you see with placebo, their nasal polyps quite similar, but with dupilumab, significant improvement, really, really great improvement here. And over on this end, we see our FEV1, and we're looking at kind of the mean changes throughout, and I would say, importantly here, you can see this is the dupilumab group AERD. And then, hopefully you can see that. This is the placebo group AERD. And then here we have the dupilumab non-AERD group. And I thought it was really amazing because, of course, you can see this difference between the AERD patients that got placebo versus dupilumab. But wow, look at how close these patients are to the non-AERD group. And I thought that was really, really, just a great visual interpretation of what a benefit we can get from some of these biologics. The next biologic that we're going to be talking about is Omalisumab Zolair, one that we also are very familiar with. As we know, this is an anti-IgE via the Fc receptor blockade. And the first thing that I just wanted to point out is just something we can kind of help to explain things to our patients. We had just started off this talk by saying that ARD is not IgE mediated, and of course it's not. And I think if patients start to look into omalizumab, they might be asking you, why am I using this medication? But of course we know it's not just that, right? When you're looking at use of omalizumab, it really is beneficial in a number of factors. It decreases mast cells, basophil activity, and also induces this reduction in LTE4 production. So I think that's just something that I'm sure everyone already is explaining to their patients and whatnot, if there's that consideration for them. But I think it's something that if I were a patient, I might be confused on. So I included that there. Next, we're going to look into this study that looked at omalizumab use for aspirin hypersensitivity and leukotriene overproduction in AERD. And here you can see, once again, really, really beautiful improvement to those LTE4 production levels. So here we have the group with the placebo, and here we have the omalizumab group. And then here you can really follow with time that this placebo group really has this rise that we do see with our AERD patients, whereas the omalizumab group really does not. And I think that's just a really good indication that they are looking quite similar to non-AERD patients, which is a good thing. Oh, whoops, sorry about that. So next we can look at this study, which looked at omalizumab specifically with use during aspirin desensitization. I think, we talked a little bit about aspirin desensitization. We honestly could spend a lot more time on aspirin desensitization in terms of how the mechanism is and things that we can do to help our patients. But I think all of us would agree that anything we can do to improve our patients' symptoms or their tolerance while still maintaining the desensitization is what we want. And they had looked at this. So here we have our, once again, urinary LTE4 marker that's being measured here. We have the beginning of the study, and here they have these omalizumab non-reactors and they have omalizumab reactors. And really, in this study, there were a number of patients that had absolutely no respiratory reaction during desensitization, and some of them who did, and that's just why they had categorized these into these different groups. But I think the important thing to note is that in this placebo group, they had this really, really, large rise in their LTE4, a little bit in these omalizumab reactors. And then following, the omalizumab patients really had less LTE4 than those who have gotten placebo. So that is just showing that omalizumab was able to, in a number of patients, completely resolve, or I guess reduce their respiratory symptoms or effects, and then in all of them, really improve that leukotriene amount that was measured. Next, we're going to talk about methylismab, and for the sake of time, I'm going to maybe go a little bit faster through these. I got too excited talking before, and I think we're getting a little bit close to time, so I'll just go through these more quickly. So methylismab and anti-IL-5, we're going to look at this study where they were looking at methylismab and determining how it targets different immune cells in the body, and they had this really, really beautiful diagram that I think is quite helpful. Once again, here's this QR code. Apologies for not spending more time on this. But what they found in this study was that IL-5 inhibition with methylismab decreased the production of prostaglandins, and it decreased the signaling on mast cells, eosinophils, and epithelial cells, including CRTH2. And I think this study, just really helps us to understand. We talked a little bit about cellularly what's going on in the body, and I think this is a really clear diagram which shows the benefit of using methylismab for those reasons. Additionally, methylismab is really beneficial in patients in terms of reducing their needs for surgery. As we know, patients that have ARD, a lot of them will have polyp regrowth in less than 6 months, and that's something that's quite frequent and can be quite bothersome and distressing to our patients. And here in this group, the group that used methylismab, you can see placebo here, methylismab here, they, with time, had a significantly lower percentage of patients who needed surgery. Of course, they still did have some, but it was much improved here. And I think that's something that can give us some insight into one of the potential things we can do to help our patients as we help to manage their AERD. This study looked into longer-term efficacy of methylismab, and specifically I wanted to highlight some aspects of this. So in this group, I will mention that they had looked at exacerbations and whatnot. They looked at the need for oral corticosteroid use, and they had started off kind of with these groups separately, but then they did transition a bit later on so that there was more methylismab use. And you can see that in terms of exacerbation, significantly less when you're using methylismab, and in terms of oral corticosteroid use, just really brings down that need really nicely. And once again, I'll go past this for sake of time, but there is that QR code there. And then next we'll talk about benralizumab, which is the last of our biologics in this category. And with benralizumab, just wanted to say similarly, a very similar kind of study, or I guess thought process had happened. They were looking at oral glucocorticoid sparing effect of benralizumab. And once again here, there was this really nice improvement to our patients who had been able to get the benralizumab. If you see down here, time to first asthma exacerbation, with time, much less percent of patients with benralizumab use had exacerbations. And then if you're looking here, you can see their median changes in their oral glucocorticoid use, and once again, much less use here, which is really great to see. So now after talking about these three, our trifecta, we're going to talk briefly about dietary changes, a little bit about surgical intervention, and then talk about some future directions. So dietary changes, I think, is really interesting and exciting. It's something that I had not really even thought to look much into back when I was a resident, when I was first learning about AERD. So I'll just highlight two main studies that I had looked at. This one looks at dietary fatty acid modification for treatment of AERD. And in this group, they had patients which were receiving much less omega-6, much higher omega-3, and they looked at kind of what that result revealed as. And here you can see they did have this improvement to the urinary leukotrienes once again. That's something that, as we know, is a key mediator for our patients. And this is, I think, quite exciting because we have a lot of patients who, for whatever reason, they just would prefer to do things without medications if they possibly could, which I think is a great thing to avoid those if you can still have good efficacy in their management. And for these patients, it's a consideration. You could discuss with them about diet and talk about these kinds of studies to help them make their decisions. The next study that I wanted to talk about related to diet looked
Hey,
at...
Stacey, wait a second. So
Yeah.
did they measure any clinical outcome? I mean, did the dietary change make anything clinically better, or just change their leukotriene biology?
And I'm sorry, Dr. Altman, my computer just cut out for a little bit. You asked if they had
Did
any...
they get clinically better? Do they have
They
better
did, they
asthma? Do
did,
they have
yeah. I didn't include this portion, but they They specifically looked at their SNOT-22. Oh wait, goodness, I am the wrong grouping. Let me go back to the right trial. Apologies. Yeah, so for this study, if I'm trying to recall, they had looked at a number of different asthmas. They had utilized their asthma control questionnaire. The change in FEV1, I believe, was not significant, but patients subjectively felt that they were doing much better. And then they also had some other various, I guess, survey-based results looking at their nasal scores. So if I'm recalling correctly, there was a significant improvement to their symptoms and how they were feeling, but in terms of FEV1, there wasn't a significant change. And that is something that, of course, should be mentioned. Thank you, Dr. Altman, for asking about
I
that.
mean, I find it hard. Every cell in the body can make arachidonic acid from its membrane. So it's hard to
Mhm.
believe that changing how much you eat would change the substrate for production of prostaglandins and leukotrienes. You've got it all inside your body in the first place in every cell membrane.
That is definitely very true, and that's something that I think all of us are thinking about as well. But with this, I think even if there isn't a change in FEV1, even if there's not some of the specific factors that we find, I think a lot of our patients come to us and they are patients who they might not have a very bad FEV1 score. They might not have, really a lot of the objective findings, but they have a lot of these bothersome symptoms, and that really impacts quality of life. So I thought this was a nice thing that they did have improvement to their ACT scores and that they felt that they were doing a bit better. But I definitely agree. This is something that absolutely should not be the only thing we recommend. This just might be something to help patients if they're making decisions so that you can have that dual partnership with them. But definitely agree with that. Thanks, Dr. Altman. And then quite similarly here, we have the study looking into a low salicylate diet. And with this study, quite similarly, the patients, I will tell you, did not have a lot of objective findings of improvement to things, but they did have pretty significant subjective finding improvement. So they had their SNOT-22 score, and they had a pretty high improvement in terms of how they were feeling if they were on this low salicylate diet. And I thought that was quite helpful to understand because, like we mentioned, a lot of times patients have primarily an issue with their symptom management, and that's something that I think if we can give them more input on what they can utilize to make them feel a little bit better, I think that's a really good thing. This group did also look at a number of other factors here. Specifically with the symptoms, they broke this down into different categories, and as you can see across the board, improvement throughout for the patients here, which is great. And then really briefly, I'm going to slip this in here and talk about just surgical intervention, only to say that today is our polyp is our word of the day, so that's going to be what you guys want to utilize when you're filling out your surveys. And the important thing for us is, of course, is to have these patients have their polyps removed prior to aspirin desensitization, so have them take a visit to ENT, and of course, in terms of the mechanisms of how we remove those polyps, we won't get into that specifically. But I think things you want to tell patients is just regarding the regrowth rate. As we mentioned, about 50% of patients have regrowth of polyps in under 6 months. And by the time that patients see us, they've gone through multiple surgeries. These patients typically have about 60% with 2 or more polyp surgeries and 10% with 5 or more by the time they see an allergist. So that's quite a high number and something that I think we want to be mindful of, that patients have been going through that. So finally, in our last few minutes, we're going to explore some of the new up-and-coming potential treatments for AERD. These are things that are really quite exciting, and I wish I had saved a little bit more time for this, but we'll go through it. And if anybody has questions or whatnot, please ask. Just as a quick reminder, we're going to pull up our initial pathway here, just talking about prostaglandin D2, kind of coming over to these kind of receptors. Specifically, we have this TP that we had talked about. And here, I want to think about, this question that's been posed as how can we target more systems? How can we target more portions of this pathway? And in this study, which is ongoing, they're looking at the efficacy of ifetroban, which is a thromboxane receptor antagonist. And I think that's quite exciting because, of course, we know that the TP has this muscle smooth muscle constriction aspect. And I think if we can target that, that's going to be quite exciting for us to look forward to for the future. So I think that's something all of us will be keeping our eye on. Another thing that I wanted us to keep in mind on was something targeting another portion of this leukotriene pathway. As we know, we have xylutone, we have montelukast. But here, something that I didn't specifically mention in as much detail before, just due to time, was that we know patients with AERD have this increased synthase here in this process. And part of that synthase, actually, we now know is on platelets that adhere to our other hemophilic cells and kind of induce this production. So then this question pops in of, can we target this in any way? Is there something we can do to target this? And here we have a trial that I thought was quite exciting, where they looked at Prostaglandins, which is known in medicine, general medicine, but hasn't been quite known here. And they looked specifically at how this affects patients, and that's something that I think is quite exciting. We'll have to all watch out for that. One thing that I wanted to bring back from earlier is we had discussed about this dimixtrimol lymphopoietin, which is a protein in the cytokine group, and it's very important in the role of maturing T cell populations. And with this, it has a lot of control on prostaglandin D2. So with this question, you see this here and you see how high this raised up even when everything else seemed to maybe be improving. And I think this raised questions of, can we target this in some way? And researchers are. So they are targeting with this Methylismab. And this is something that for me was incredibly new. I did not know much about this before. If anybody knows anything, I would love to learn from you all. Please let me know. But this is something that has been looked at in patients with severe uncontrolled asthma. And if you look at the results of their study, like comparing the placebo with the treatment here, really significant improvement kind of across the board. They had less eosinophils, less FeNO, and just really had a lot of improvement there. So I think that's quite exciting, and that's one that we're going to need to keep our eyes on in the future.
Stacey, that's going to be a new biologic probably in the first quarter of next year.
Oh, is it really? Oh, that's so exciting. Dr. Allman, thank you for letting me know that. I was wondering when that was going to be in the works. So I suppose I'll read even more about that mechanism and be ready to hopefully utilize that to help our patients. How exciting. So it looks like we have 1 minute. I'm so sorry, everybody. Let me just move on quickly and mention 2 more studies that looked more so into kind of the genetic aspects of this. In this study, they had looked into a number of SNPs, and they did find that this RS573790 and the MS4A2 gene was one of the top variants associated with AERD. And this makes sense when you look at it. I wouldn't have thought about this, but it does make sense because the MS4A2 encodes the beta subunit of the Fc epsilon RI beta. And really with this, I think that would, I guess it would make sense. I just had never thought about this kind of evaluation until I was doing a little bit more research. So that's quite exciting. And then the final study that I wanted to just look into is this, where they looked at variabilities in HLA-DRB and DQ, the genetic variabilities, and they did find, I put this conclusions down here for us all to see, that these two were related or predisposed in patients in AERD, whereas these actually had a negative association with AERD. And I think that's something that's really exciting. Of course, very, very early, even though this was back in 2015. I couldn't find anything with people looking into these specifically. I'm not sure if that's something that anyone knows about. I would love to hear if anybody has information on that. But that to me was really exciting that we might have some ability to understand more so about what's going on with our patients. And that is all. So hopefully by the end of today's talk, you all were able to take a journey with me to understand the pathophysiology, the clinical presentation of Aerd, review the current managements and the known mechanisms, and explore future possibilities in the management of Aerd. Thank you so much for taking your time this morning to take a listen to me. Hopefully, together we can all lead our patients down this path and do some good for them. I know it's a little bit over time, but if there are any questions, happy to discuss anything now.
Hey, Dr. Chen. Yeah. Hi, this is Greg Davis. I have a question for you if we have time. Fantastic talk. I did miss part of it. I had to check in a patient. It seems like, and I'm an ENT that does sinus surgery, Dr. Chio. We haven't met yet. It seems like when I send patients to allergists for aspirin desensitization, about half the time now, the allergist is choosing to do a biologic rather than aspirin desensitization, even though their center does that. What's the right answer? What should we be doing in AERD patients? Should they get a biologic up front or should they get aspirin desensitization?
Oh, goodness. I feel like there's so many things to think about in that question. You know, this is a question that I very likely would want to defer to one of our practicing AI docs who might know more. I would say that based on the literature, you know, the biologics, it really does seem that there is a lot of benefit there, and potentially that's something that might help patients in a number of different aspects without them needing to take that daily aspirin. Of course, we all know that when you get the desensitization, you do have, you know, that risk of small risk, but that risk of gastrointestinal side effects, that risk of bleeding and whatnot. I'm not sure for those patients they had specifically contraindications or maybe precautions, but that'd be all that I can think of. Maybe anybody else or Dr. Altman, if you could weigh in. That's a really great question.
Yeah, well, Greg, I was going to ask exactly the same question. If anybody is still doing aspirin desensitization, if you sent it to me, I would probably try a biologic first. It's usually a lot of work to do the desensitization, and you only get, you know, a pharmacologic desensitization. If they forget to take the aspirin for 3 to 5 days, you're back to square one. Drew, I don't know, you may want to weigh in. Are you guys even doing aspirin desensitization at the university, or is anybody, Paul McBride, if you're listening, is anybody in the community still doing it?
We're not right now, just logistically. The Spiro, we're having difficulty doing just because of COVID, and then it's been a staffing issue with nursing because you do need devoted one-on-one nursing for basically a day and a half for most of these patients. But, you know, it was all we did for a long time, but now we have the biologics, and there may be a role for both at some point. But yeah, and there is some evidence to show that being on one of these biologics makes the desensitization safer. So something to think of, but just for logistical reasons, we haven't been doing it over the past year and a half.
Yeah, anybody else listening want to comment on that? Rennie asked a question, any data on the combination of biologics? Drew just mentioned that. But I would probably put a person on a biologic first and give them 6 months or something before, if that didn't seem adequate, then probably go through the procedure. But I doubt that very many aspirin desensitizations are being done here. Again, Drew just raised a very good point. We have to do spirometry. Doing spirometry in COVID is almost impossible in most places. Stacey, thanks very much. I won't ask you to answer this question, but as I was listening to you, you discussed all of these pathways as far as their pathology. Mm-hmm. So we must have these pathways for some useful purpose, or we wouldn't have evolved this way. So next time I see you, tell me why we have these pathways. What's the value of prostaglandins and leukotrienes for humans? Mm-hmm. But don't answer it now. So anyway, thank you. We got to move on to another conference. Thanks very much.
Thank you, everybody.
Okay.